viewers, welcome to this week's episode of Health Watch on Anglican Cable Network Nigeria. I am Angela Mweze. Sickle cell disorder is one of the commonest inherited disorders in the world and is an increasing global health problem. Estimates suggest that every year approximately 300,000 infants are born with sickle cell anemia globally, and these numbers could rise to 400,000 by 2050. 70% of the over 300 children born annually with sickle cell disorder occur in sub-Saharan Africa. Nigeria alone has been estimated to have at least 150,000 newborns with sickle cell disorder annually. It affects 2 out of every 100 children born yearly. So the question on the program today is, what is sickle cell anemia? How is it gotten? Can it be treated or managed? This and other questions shall be answered by our guest on the program today. He is Dr. Tamunomieibi Wakama. He's the consultant hematologist at the National Hospital, Abuja. You're welcome to the program.
Thank you very much.
It's good to finally have you here. Welcome.
I'm always itched to come here.
I'm finally, it's good to have you around.
So to be a regular program now.
Yeah. Good to see you, sir.
Thank you.
All right, so today we're discussing sickle cell disorder, anemia, disease. We've been talking about which one goes better. But first of all, we want to know what sickle cell is, because there's a lot of, I believe, misunderstanding of what sickle cell anemia or disorder is.
Well, sickle cell disorder, like you said in your intro, is an inherited disease. It's global. But coming back home, you use the word sickle, and that is where it derives its name from. As we all know in common biology, the blood is composed of the cellular component and the plasma component. And in the plasma component, you have majorly the red cells, the white cells, the platelets. So we are talking about something about the red cells, okay? And the red cells take the shape of a sickle. If you are conversant with the flag of Russia, you must have seen the sickle. Okay, yeah. Or for
like
those who farm,
yeah.
For those who farm, you can see it's a farming instrument, actually, what you call the sickle. And not ordinarily, the red blood cell is round, or really has a donut shape. Okay. And when it sickles under certain circumstances, it becomes what is known as the sickle cell or sickle red cell. So that is essentially what it means, a red cell, which is ordinary round or donut shape, taking the shape of a sickle. So it becomes sickle red cell. Okay? Okay. So by way of pathophysiology, actually that one. And that happens ordinarily, even in those who are sicklers, their blood is normally the normal red shape. But under certain circumstances, especially where there's the deprivation of oxygen, the red cells take that sickle shape. So the sickle shape looks like kind of a C, C, half 1/4 moon, or whatever it is.
All right, so you see the structure of the 1/4 moon.
I'm just trying to for you to visualize what it is. I'm sure when the moon is starting, the 1/4 shape and all that. But essentially, just take that C shape or sickle shape. So that's where the name actually derives. So essentially, it is sickling of the red blood cell that actually gives the name sickle. So you said it is an inherited disorder. In other words, you are born with it. You are born with it in the sense that it's not something you just pick up as we get infection from the environment and all that.
They cannot be transmitted from one person.
Transmission is
it's a bigger word.
Relative, because yes, transmission in the sense that you can pass it on, but it's not something that is contagious.
Contagious, okay.
Okay,
that's the word.
Transmission, yes, you can transmit it to your children because you also got it from your parents. Okay, so it's inherited or it's genetic, because what you derive from your parents is the gene to make a particular thing, the color of your hair, the eyes, their shape and all that. Certain of these things are derived from the gene. So the parents that have this sickle cell gene, okay, also transmit it to their children, and so that's why it's inherited. So, but the inheritance, we'll come to talk about it later, how, you know, a child can have, and there are various ways that you can actually inherit it, depending on what the genotype of the parents are. But simply put, it is an inherited disorder, and it is something that you get from your parents, and so you don't really have a choice. You are born with it if your parents have it. But what I've just said is that the whole concept is that the red cells take an abnormal shape, and there's consequences when this abnormality happens. Because ordinarily the red cell, like I said, which is donut shape or round, has a free movement within the blood vessels. Okay, and of course the major component or function of the red cell is to carry oxygen.
That's the hemoglobin.
Yeah, in the hemoglobin is in the red cell, carries oxygen from one part to the other, and then the other component is carry carbon dioxide also out of the body. So when this sickling happens, you find out that these cells no longer have that free movement, and they tend to clog the blood vessel. And when they clog the blood vessel, what happens is that the parts distal to where the clog is become deprived of oxygen. Okay, and so you have a lot of problems, which we'll discuss in the symptoms and all that. So, and then also the red cell has a lifespan. Okay, ordinarily the normal red blood cell should last for about 120 days, but in this case the red cells die off very frequently, within 20 days or less. Okay, so there's always this dying of the red cells, and so they don't last long, and so the person also suffers from lack of enough
so that the
blood
sickle cells, the sickle cells die off faster.
The lifespan is very short. Okay, very short, extremely short. So there's always a rapid turnover of the red cells because they are dying and do not last the normal lifespan of 120 days. So two things majorly: the cells dying very frequently, and then this clogging of the blood vessels preventing oxygen from getting or nutrients to the other parts. And so you have the problem of lack of blood or anemia, and then pain as a result of the lack of oxygen to the pump component. So these are the two major, you know, mechanisms by which the people suffer. And then there are other issues of infection and all that, which we're going to talk about.
While I was doing my research, I discovered that it's confined to certain areas. You know, you have them in sub-Saharan Africa, then some part of India, and some of the. Why is it common in those? Is there any particular reason why it's common in those regions and not just everywhere?
You know, in the intro, you also said it's a global thing. It's a global thing, which means it's not confined to Nigeria. Also, we have a very high burden because of our population. Now but it's also, like you rightly said, confined to what we call the malaria belts.
Yes, okay? I read about that. Yeah,
we have what we call the malaria belt, and there's a reason for it. It's called the polymorphism. Now, malaria and sickle cell has some relationship. Okay, so those of people who have the AS and those who have the SS. Sometimes you hear the fact that, oh, those who have AS don't suffer from malaria. Not really true.
Yes, I've actually heard that.
And those who have AA die from malaria. Yes, there's some relationship. So this also has also propagated the consistent rise in the number of sickle cell and in a particular area. For example, sub-Saharan Africa, the Mediterranean, India, and all that. So wherever you have an endemic malaria endemic areas, you also have high incidence of sickle cell. But like I said, there are reasons, because those who have AS has a way of resisting the malaria attack. Okay. And so they live longer, and then the AS gene is now further propagated, and of course what we'll come to talk about later, the AS and AS are always continuing to marry, and so the sickle cell is continuing since the time we knew of it and up to this time. So, but there are definitely that malaria belt that has also further enhanced the advancement of sickle cell.
Something like a natural selection kind
of
thing.
Well, definitely it is, and that's what is called actually natural selection. So somehow, you know, as we also, like was it Junior Achibeda said, that as we, you know, the hunter practices to shoot without missing the bird also is also
looking for us
seeing how to survive. So while we are also striving as much as possible to contain it, nature also have a way of this thing also trying to see how it can survive, you know, so somehow it's been on and on.
Okay, so let's now look at how people get it. We've established that it's not contagious.
Yes, it's not contagious.
But it can be transmitted. So how, from parents to children. So how do people get?
Okay, like I said, it's genetic.
Okay.
We transmit whatever we have to our children. From the basic color of our body, our eyes, and all that. So on the chromosome, which everybody has, there are genetic components, okay, and these genetic components we transmit to our children.
So the genetic on this chromosome, the genetic component determines what a child.
What, of course,
you know how he will look like and what he.
Even to the extent of whether the next child is going to be a boy or a girl, so it's also genetically determined, and it has to be from man and woman anyway. Yes. Okay. So now there's what we call the hemoglobin genotype, okay, as against blood group, which, like I said, sometimes people confuse. You ask them, what is your blood group? You say, I'm AA. You know? So, but the genotype is not blood group, it's different. So the genotype is that every person, okay, has a particular genotype, which the person has derived from the father and the mother, okay? So you derive one, for example, let's take for example, the common one that we all know, AA. You have SAS, you have SS. So nobody just has A alone.
Yeah, of course.
Because you derive one from father, one. So we're just looking at schematically. So a man, for example, has AA, okay? And then he has a wife who has AA, okay? Now, in transmission, you have transmit one component. The child derives one component from father, another component from the mother. So, in a case where the father and the mother are both AA, the child can only get A and A from the two of them. Okay. But if for any reason the father is AS and the mother is AS, okay. Now, the child can, in various permutations, okay, derive so many possibilities. Can be A from the father, A from the mother. Can be A from the father, S from the mother. Like I said, the father is AS, the mother is AS. And then it can also be AA, that is A from the mother, A from the father, A from the father, S from the mother, and S from the father, A from the mother, S from the father, S from the mother. Okay? So you can see the various combinations that the child can derive.
So that's in the case of AS.
That is when they are both AS. Okay? Like we said, if they are both AA, there's no problem because all the child can derive is A and A. Okay? But we are looking at a situation where the father is AS and which is the commonest that we have, okay, that has continued to give rise to the problem we are discussing now. So under this circumstance, the child can actually derive AA, AS, SS. Okay. Now, why am I taking time to explain this? Who can derive what? I don't think you and me right now have that control, really. Yes, we have, as of science today, we have. But by nature, it's not really easy to determine how this will be. So a child can come up with any of these combinations, okay? So now, before now, you hear, okay, if a family is going to have 4 children, one of them will become sickler, okay, by this combination. But that is not true. The point is that there's a 1 in 4 chance. 1 in 4 chance. I hope I'm trying to get, I don't know if I'm Right, I mean, clear enough. That is for every child that is born of this combination. There's a 1 in 4 chance. In other words, of the child having SS. In other words, the child, any particular pregnancy,
can have
the child has a 1 in 4 chance of becoming SS. So in other words, he can be AA, can be AS, can be AS again, it can be SS.
Okay, we'll just hold that thought and go on a quick break. When we return, we'll continue that part of explaining how people get the sickle cell. We'll be right back, viewers. Welcome back, viewers. Before we went on the break, we were discussing sickle cell disorder, and we were discussing how people get it. And our guest is still Dr. Tamunomieibi Wakama. Thank you very much, sir. So before we went on the break, we were discussing how people get it, the chances of getting it. So it's not that, like, people think that if you have 4 children, by the time you get to number 3, then you stop, because number 4 most likely will be the one that have, because that's what people
that's why I spent actually some time to try in the simplest of ways to explain this, because this is, like I said off camera, there are a lot of misconceptions and there are a lot of myths, you know. So you have this problem of, it doesn't matter if we have 4 children, maybe one of them will be, but you have instances where people have had 4 children, all 4 are sicklers.
Wow.
Okay, the same way you have families where maybe 4 or more children, maybe 1 only is a sickler and all the rest are not, either AA or AS. Okay, so it's not, the probability is a matter of probability or statistics, really, you know, and chance. It's for every child, not the number of children. So for every child, in other words, for every pregnancy, that child has that 1 in 4 chance of becoming sickler.
So it's possible.
That is if both of them are AS and AS. Okay.
Then in the case of AS and SS.
In the case of AS and SS, the chances are even
higher,
more. Okay. The chances are more. But then in the case of AS and SS, there's a probability that the child can be AS. You understand? Because you derive S from the mother, because if the mother is SS, all the child can derive from the mother is, of course, S. But it can also derive A or S from the other party. So there's a probability that a child can actually be AS or SS, SS, and AS. So there is now 1 in 4 chance of AS, really, in this case. But more than 75% chance of having a sickler, okay, in this case. You know, so the chances are high when one is AS, another is SS. And of course, if the both of them are SS, it's 100% chance that, you know, except, of course, what we call the mutation or something happens. Okay.
So is it possible anywhere that people do not really know their genotype? Or can it be mistaken? I don't know. You hear people say, oh, before I got married, I was AA, and now suddenly I'm AS.
Well, not suddenly AS, of course.
Because it ought to be standard, isn't it? It has to be established.
No, I think we may be a little bit technical. Somebody has asked me, can people who are both AA or no history of sickle cell have a child with sickle cell? Possibility, yes, possible.
Oh, wow.
Hematologically speaking, possible. Because what is it? Sickle cell is actually a case of mutation. And mutation can be a point mutation at any particular time. Okay? We've talked about transmission, in quotes, deriving from. But when there's a mutation at any point in time, of course, anything can happen. Because what really has happened in sickle cell is that something went wrong in what we call the amino acids. And every protein is blood. What they're talking about, the hemoglobin is actually a protein. Okay? So, and it's a combination of proteins that leads to amino acid that leads to proteins. So when there's a change, a switch, the whole thing we are talking about is just one switch in one amino acids in the chain. And so if at any point something like that happens, of course you can have this problem. So that is very rarely anyway. But I'm just saying that hematologically speaking, it is possible. But generally we are talking about where, yes, both parents are, and then we are talking about the offsprings. Okay? So coming to the issue of people not knowing, yes, that's why I said a lot of times people do not seek, you know, help where they really need to seek help for help. You can go to any hospital and do a blood genotype or blood group, and you can be given any results. And as they say, garbage in, garbage out. So if you go to a place where there's no quality assurance and somebody just cooks up something and gives you a result, of course, you are not educated in that line, so you just accept whatever that is given to you. So you go about, it's like a branding. You have been branded that you are
That's
AA,
what you believe you are.
So that is what you believe you are. And so you go about, especially we see that a woman comes to antenatal care because routinely they are tested for blood group, they are tested for genotype. And then they test you and say, oh, madam, you are AS. And say, well, no, because when I did it last year, I was AA. Okay, now it cannot be. So it all depends on where, and of course, genuine mistakes happen anyway. I'm not ruling out that. But where there's proper quality assurance in whatever you are doing, and that's why whenever we want to do this, because these are lifelong things, and they have a lot of implications. So we need to know where we do what, so that we don't have, you know, these complications of further complications.
So it's important to go to a proper clinic.
Proper clinic and a good lab that you can actually do that. And also an advice for people who do these things, because it's a matter of, should not be taken lightly, so to speak, because you are branding somebody and it has a lifelong implication. Because if you tell somebody that you are AS or AA and the person believes that that is what he is and goes on to take a decision that will affect his marriage, his children, and all that, it has a chain of reactions that you that did it may have even forgotten that you are the person that did it, you know. So, but some people sometimes don't even bother to, okay? And a lot of people say, well, what you don't know, it doesn't matter. So you have that attitude, it doesn't matter, so take a chance and just go. And then there's the third category where, well, even when they know, take a chance and just do. After all, well, we know that 1 in 4 chance. So there are these categories of people, those who were mistakenly branded, those who did not bother to know, those who knew and took a decision to because they believe that, well, God will do it.
Let's play the trick.
Okay.
Okay. Well, that's very important to know. Now, the next question is the symptoms, and why I'm even particular about the symptoms is I know in the past, you know, when a child is sick constantly, they brand it either Obanje or Abiku or something. They give them some name, and then they say the child just wants to die and come back. That was in the days, you know, of ignorance. You know, people didn't know. So, what kind of symptoms are parents? Of course, I should believe that now, before a child is born, somehow you should, you know through, you know, the tests that go on. But what are the symptoms?
Well, the symptoms vary, but I just alluded to some of them, or the general, broadly, the frequent breakdown of red blood cells, and then the other aspect of obstruction causing, you know, lack of oxygen to the. So broadly speaking, you have 2 major categories of symptoms. Okay, pain, which is the commonest, and like I said, pain in the sense that, you know, there's deprivation of oxygen to distal parts, and so the part that is deprived of oxygen, you know, gets what we call infarction and all that, and then there's serious pain, and then the frequent breakdown of red blood cells, which we call hemolysis, you know, makes the child to be anemic, lack of blood. And then because of the product of the breakdown of the red cells, you have what we call yellowness of the eyes and the body. For those who are very fair, you can see them yellow, and then, but of course, in the eyes, you see yellowness of. So, broadly speaking, okay, so you have yellowness of the eyes, okay, and then the pain aspect, and then of course the lack of blood. But the first thing that people take notice of to know that this child may have a problem is what we call the hand-foot syndrome. Okay. Okay, hand-foot syndrome. The hand-foot syndrome is the more like the first thing that, you know, raises that awareness that there's something wrong in this child. Now, hemoglobin, like we have just said, which is the part that carries the oxygen. Okay, there are various types of hemoglobin, but this is not the forum for it. But we are looking at the hemoglobin that the child is born with, because we are talking about a child that has been born now. We are not talking about when the child is in the womb. Okay, there's a switch really from time to time until the time that the child is born. So when the child is born, there are 2 main categories of hemoglobins. Okay, it still has a little of what we call the fetal hemoglobin. That's the hemoglobin that is predominant when the child was in the womb. But at that time that is born, most of the hemoglobin that is formed at this time is the adult hemoglobin. So you have mainly adult hemoglobin and the fetal hemoglobin. Now the fetal hemoglobin goes on for a little while. So while the child has a high component of the fetal hemoglobin, he may not have much of the problem of sickle cell. Okay? But as time goes on, by time he's getting to about 4 months, 6 months and all beyond, the level of the fetal hemoglobin goes down to almost, you know, the level that is insignificant, and then the adult hemoglobin now begins to be more prominent, and that is where the problem begins. And that is why the routine genotype that we do, you don't do it for a child that is about less than 6 months old, because you're going to have confusion with the fetal hemoglobin and the adult hemoglobin. So we are looking at mainly when the adult hemoglobin is more than, you know, has become more prominent in the child. So this is where the problem begins. And then the child begins to have some swelling of the hands and of the feet. And as just said, the hand-foot syndrome, okay?
That's when the child is at, after
about 6 months and beyond, okay? So you see a child begin to cry, pain all over, and at that time, of course, the child cannot speak. So you cannot tell you, I have pains in my hands or in my leg. But now what is happening is that this, you know, clogging of the blood vessel that I talked about has started.
Cells,
okay, the cells are beginning to sickle under certain conditions, and so the vessels around the hands and the foot, because they are very narrow, I'm talking about the capillaries and the small veins now, begin to get blocked, and and then they become inflamed, and so the child begins to cry and pains in the hand, and there's swelling in the hands and the feet. Okay, for those who are vigilant and will immediately see this and know that something is wrong. Okay, and then of course there are other things. So that is the first thing that happens. That's what it is, the first sign. And of course, the other things are the child begins to get discoloration of the eyeballs, the yellowness I'm talking about, because of the frequent breakdown of the red cells. So there's a component of the blood that when the red cells are broken, what we call the bilirubin. The bilirubin now, begins to manifest in the eyes and in other parts of the body. So you see yellowness of the eyes. But don't forget, you can also have that in certain other conditions. So I don't want people to think that if you have a liver problem, you can have jaundice and all that. But for a sickler, that is. And that's why if you look very carefully, if you see most sicklers, there's this continuous yellowness of the eyes, okay? And some of them get embarrassed that their eyes are perpetually yellow because this breakdown of red cells is almost a continuous thing. So regularly,
because it doesn't last long, just as you said earlier.
So there is subtly, but of course, if the liver is okay, the liver takes care of this breakdown products and all that. But when there is exacerbation of this problem, for example, what we call this crisis, which we're going to talk about, you find out that the yellowness may increase and all that. So the major problems are the pain, and then the lack of blood, the anemia, okay? And then the yellowness. Now, we have what we call the spleen, okay? The spleen is important. It helps us to fight infections, okay? Now, as the child with sickle cell continues to grow, the spleen begins to shrink because of repeated, what we call infections, or obstructions in the vessels of the spleen, and so it shrinks to an extent that it becomes almost non-existent. Now when this happens, you find out that the person is unable to fight infections as any other person would have done who has a normal spleen. So infection also becomes a major problem. So they have to battle with infections. And of course, you can imagine somebody who is regularly breaking down the red cells. And then when this person now has malaria, and you know that malaria, what happens to malaria? The malaria attacks the red blood cells, okay? So malaria attacks the red blood cells. So when malaria attacks the red blood cells and breaks down the red blood cells, so you can imagine double jeopardy. So the cells are breaking down on their own because they can't last long. Then malaria attacking most of the existing red blood. So of course, there's complete.
So malaria is a big problem for people.
Of course, that is a major problem and a major killer of people with sickle cell. Okay.
So when you notice the symptoms, like the hand-foot syndrome, the first thing to do obviously would be to seek medical. Of course, like any other thing, is to seek medical help. And don't look for any traditional help. Sometimes, that's why, like I said, it's good that we have this information, because most times when you see the swelling, of course, we are in a traditional setup, especially in the villages, there's a tendency for them to make scarifications. And the hand, the leg, and then because the spleen in infancy in sickle cell is very big, so most of the people with sickle cell, when you see them, you have scarifications on their tummy, people trying to suck out blood or something, So because of ignorance or their belief, so the hand-foot, you find out that people can make scarification thinking that, they want to let out blood or fluid or something. And then by so doing, you're also causing more problems, tetanus, infection and all that. So when you notice this, and in fact, if you now have a child crying without any reason, it's not food, it's nothing, and I think you should suspect that something is going on. And if you now find the hand swollen, the feet swollen, and it's warm and all that, I think the best thing is to check out the child in hospital and let them do a proper workup. But if you know your genotype, of course, it also brings you to mind that yes, is that But unfortunately, most people don't know their genotypes, and so they don't really know. But I think for those who have genotype problems or are aware of their genotype, or when they have this, then the best thing is, and for any doctor that sees a child
6 months or less that is having, the first thing is to think of this.
Okay.
Not foreclosing the fact that there are other possible causes that can cause, but this is the major thing that you find as the first thing that can present in a child. And this
should be towards 6-7 months, around that.
Could be a little bit lower, could be longer, or some may not even have this as a prodromal thing. That it may not be the first thing that they can present.
But pain is very important. Yeah,
they can present with some other things and all that, but that is the main problem that they come with.
Okay, we'll go on a quick break. When we come back, we'll discuss management and prevention and the counseling part at the concluding part. All right, don't go anywhere, viewers. We'll be right back. Welcome back, viewers. Before we went on the break, we were discussing sickle cell anemia. We'll just carry on from where we stopped. So I want to discuss management of sickle cell because we have seen the symptoms, you know, in the earlier part discussion, seen the symptoms, what people should, what they notice, you know, and to go to the doctor. But management, how do somebody who already has it now, how do you start the management of?
Okay, when we're talking about symptoms, I know we don't have all the time, so I need to be a little bit, but there are certain key things I need to mention in part of this. Now, most of these children may be small for age. That is also what you may also be a pointer. The child, small for age in the sense that you see a 6-year-old child that is looking like a 2-year-old, 3-year-old child. Okay. So there's poor growth, although most of them at some point catch up. Okay. So that is also a pointer, apart from the problems we have talked about. Okay. So I've talked about the anemia, which is lack of blood. I've talked about the pain, which is the major thing in this environment. And then I've talked about infection. Infection could be bacterial, parasitic like malaria, viral, and all that. So these are key things, and they are the major killers in most of the patients. So how do you manage? You actually manage symptomatically, what means whatever the patient presents with. Okay?
That's what you start managing.
So if it is pain, of course you take care of the pain. If it is lack of blood, you transfuse with blood. If it is infection, you treat infection. So broadly, that is. But there are certain things that can predispose to some of these things. Okay, so I think it's better we look at that, because if a child has a problem, you can actually take the child to hospital and the people there will take care of whatever. But I think there are certain things that we need to do at home or immediately before we even seek help. Now, one of the major problems that can predispose to most of these problems, the crisis, is change in the ambient temperature, either excessive cold or excessive heat. Okay?
Okay.
So this is very important. So if they are exposed to excessive cold, they may go into crisis.
All right.
Excessive heat, they may go into crisis. Excessive stress, exercise, emotional, physical stress, they may go into crisis.
Wow.
Okay? So if we know this, then we're able to minimize, because like I say, prevention is better than cure. So when I don't want to dwell too much on how do you manage, because like I said, management can be in the hospital. But if we're able to manage the environment, the person properly, then we may not go into the other areas of. So let's take, for example, I said malaria is a big problem, infection is a big problem. So if we have an environment where you can prevent malaria, okay? So first step, we need to prevent malaria in these patients. And prevention can be twofold. Of course, our environment is important. We keep our environments clean, and we prevent malaria from getting to the patient through barrier. Could be net, mosquito net, could be window netting and all that. Taking care of water and all that around. So first we need to prevent malaria, because malaria is a major killer for patients with, like I said, twofold. The red cells are breaking down, and then the malaria attacks the red cells, and then so anemia. And one of the easiest ways for people to die is anemia, if it is not. Of course, when you lack blood, if you're not transfused immediately, of course. If you have pain, of course, it's pain. If you're in distress, it can be burnt. When you lack blood and you're not transfused immediately, of course, you can die immediately. So we need to prevent anything that will lead to blood transfusion.
Okay.
And of course, we know that blood is not easy to come by. And of course, even if you're talking about blood, if you want to transfuse the patient with sickle cell, you have to look for blood that does not contain sickle cell. So you need to get blood that does not contain sickle cell to transfuse the patient, except it's a dire emergency. Okay? And of course, we all know that blood itself has some risk factors. So all this, at least we need to be aware of, even when we want to transfuse. So it's better to prevent transfusion. So we can transfuse, prevent malaria, prevent infection, and if the person has infection, to treat infection immediately. Okay. So we have what we call prophylaxis. Prophylaxis in the sense that you want to prevent, and I'm sure you've heard of, in those days, Daraprim, Sunday medicine, okay, although we don't use it for sick class now because it has its own setbacks. So we give Paludrin to prevent malaria, okay, and it's going to be daily. Wow. It's given daily. And then you also give folic acid to help, boost the blood for most of these drugs. People have asked me, what of iron tablets? We don't give iron tablets really routinely to patients with sickle cell, okay? Because the lack of blood in this case is not because it's not as a result of lack of iron, okay? In fact, as they break down the red cells, they are even producing more iron. So there is always sometimes iron overload in them. So I'm saying this so that people don't just walk across the counter and say, my child is sick and let me just give iron. Iron is not necessarily contradictory, but there are people who may need it, but it's not advisable to give sick class iron tablets because you cause iron overload. For folic acid, you give. And of course, one thing that we can do, and which is very key, is hydration, giving fluids. Okay? Because, like I said, stress, physical stress can cause them to sweat and all that, and as they sweat, they are losing fluid, and they precipitate the stickiness of the blood and the red cells and all that, so they aggravate the pain. So you prevent hydration by giving liberal fluids, and if there's no contraindication, they can just drink as much as possible freely. Okay, so you advise them to drink very freely. Fluids, water, anything that is comfortable with. And if it is necessary, maybe they have infections or other things, you can give them fluid by drip. Okay, but ordinarily, you ask them to drink as much as possible. So, hydration, giving fluids, treating malaria. So, you give prophylactic malaria to prevent, but if they have malaria attack, you treat the malaria. If they have infection, you treat infection, okay? And also prevent infection as well. And then one of the ways you can also prevent infection is to give what we call penicillin, okay? And regularly, especially for children, is one of the drugs that you give regularly, routinely, okay? So they are given penicillin, okay, from infancy up to a certain age, okay? And then you also make sure that when they have infection, you treat adequately. So penicillin is very important, okay, to prevent.
But that should be on the doctor's prescription, isn't it? Is it doctor that you don't just go and
of course, and then you also give the vaccinations as any child will have. And especially there are certain vaccinations that are very key for people with sickle cell. So these are the things. Vaccination is important as any child, of course, and more so with people with sickle cell. All these are things to prevent infections. And then penicillin for people and the children and some bit of adults. Like I said, because of the spleen that is, has disappeared, most of them have to depend upon this drug to fight infections, okay? So generally, that's the way it is for as far as treatment is concerned. But I want to look more in the area of prevention and the home care. And of course, pain. Definitely pain is pain and you have to treat. But you have to treat pain in a graduated manner, okay? Because that's what we call the WHO pain ladder, okay? And where you go from simple paracetamol to the opioids, okay? And that is also very important in the area, especially the major challenge we are having, which is the issue of drug dependence by sickle cell patients, okay? So we need to be very careful, especially at home, when we are giving these drugs. There are certain things that you can just do at home, small, simple remedies from simple paracetamol, and where that fails, you graduate to something else, to something else.
So you don't just take
both of them. But if it goes beyond what it is, then you should seek medical help. And the opioids should actually be prescribed and not to be taken across the counter. But it's a challenge that we're having seriously right now. Okay, there are a lot of patients who are dependent and are abusing some of these drugs. So it's a major challenge for us.
Okay, now what of the issue on feet not growing the same for sickle cell?
Well, it's, yes, it can, although it's not really. It's also a problem because now what happens is that, like I said, the vessels, get occluded, okay? So when the vessel gets occluded in any particular arm, for example, in any particular finger, that finger, stops growing as well. So you find some fingers getting shorter than other things, so it happens like that.
So just basically as a result of the occlusion that happens as a result of the sickle. Okay, now continuing in the discussion on prevention, the issue of counseling, because it's mother and father that if the parents can't get it right, then you never have to go through, you never bring a child that will have to go through the pain, and all the the treatments that is required. So what's the counseling going to be? I know you've been in the church ministry, you're very, very involved in fact you're in charge, you're one of the heads, so on the counseling for young people, in terms of avoiding or preventing this from happening at all from the beginning.
Well, before I go into the counseling, but in my discussion on the management, I just limited it to more like the basic management, but I don't know if we are going to come on to that also with regards to the newer,
okay, that's it. Okay.
Yeah, new things that are evolving in the management of sickle cell. Or maybe I could just say that before we go into that. Okay, for example, although that is not at home level, but like I said, what I've just said is most of these things can be at home level and then in the hospital. For the pain, for example, I said we should start with something mild, and then, but when it gets to the hospital, and depending on the degree of the pain, more things are given, okay? And then also the issue, there are certain new drugs that are evolving right now that are used. You know, like we said, the whole thing is about sickling, but there are drugs that are now being used to prevent the red cells from sickling.
Sickling, okay.
Okay, so, and then there's another drug called hydroxyurea that actually, I told you, when the child is born, there's the fetal hemoglobin, that's the hemoglobin, and then the adult hemoglobin. So there are certain drugs that help to increase the fetal hemoglobin in patients, okay? So there are also drugs that are used now to increase the level of fetal hemoglobin.
All right.
So because the fetal hemoglobin does not really sickle like the adult hemoglobin, so if you're able to increase the fetal hemoglobin, you prevent the blood from sickling and then prevent all the crisis. So as far as treatment is concerned, that is also part of the drug. But I'm just looking at the basic treatment that you should give, and looking at the two various components of pain management, and but these are other areas that, you know, people are benefiting, apart from the bone marrow transplantation, which we may just touch a little bit. So talking about counseling, so that you just sit down and watch and ask yourself, sickle cell is been with us for, I can't remember how.
I mean, as old as before medicine.
So why is it still a problem today? So I asked myself, and I don't know where anybody else. So why is it still a problem today? Because it's been, as far as, because it's one of the most studied, in fact, first genetic, one of the diseases that actually, you know, science went into to look at the genetics, and a lot of work has been done. And then today we still have such a burden, especially with us in Nigeria. So you begin to wonder, you know. So a lot has been done, really. And talking about counseling now, you know, because it's genetic, people have come with so many ideas, you know. Oh, people should not, people of this genotype should not marry this genotype. Of course, if we do that, and if that is possible, I think that is the solution to the problem. Truly, that is the solution to the problem.
So no AS should marry an AS.
If no AS marries, no AS should. Okay. If we have a situation where AS and AS does not marry, or AS, you know, so it's something that actually, by natural means, you know, you can actually, you know, put an end. But because it has been on with us for so long, it means that it is not as easy as, you know. So a lot needs to be done, you know, and that is where really counseling comes in. But I'll also delve just small into the new things that are happening, you know, by way of science and all that. Now, if we really counsel people properly and they know the dangers or the difficulties or the challenges, it's easy for them to take a decision
early enough.
A decision early. So, for example, people know what happens when a child with sickle cell goes into crisis. Now, we've said a lot. I don't know if you've imagined in your mindset what I'm really talking about when I say somebody is in pain. If you've never seen it, you've never seen it. You cannot imagine it.
Can imagine it.
I can imagine it because I know, I've seen, so people really need to see to believe what it is. So it's easy to say, look, if you have a child with sickle cell, you will be in pain. So what? I don't go through pain. But you see, it's not the same as when you have experienced somebody. You've lost somebody. There are people today who I know that have a family of 4 children with sickle cell.
4 children with sickle cell?
And a child with sickle cell who has a bad history is a nightmare, because you are in the hospital more than you are out of the hospital. So if you have 2, 3 children with sickle cell, you are in the hospital all the days of your life. Wow. So, or even when you're at home, you are in trauma, you are in distress. So it's really easy to just tell people, okay, it's pain, it's this, but you need to see to believe, and it's not something to wish for. And we really need to sympathize with those who have the problem, because it's not something they desired or brought upon themselves. But it's there. So the important thing is, how do we now prevent such occurrences? And it's by counseling, okay? And counseling, there are people who are trained, called genetic counselors, not peculiarly to sickle cell, but, you know, like I said, we say genetic problems. So there are people who counsel people on genetic, because there are so many other genetic disorders, okay? So they are trained people who counsel. And I think everybody should learn some little bit of counseling to, you know. And like I said, behind the scene, counseling is not advising people. I think I need to stress this point first before we really go into that. It's not advising people. It's not telling people what you believe in that they should do. Okay?
Or putting an instruction.
But you have facts. Like I've just said, I see people in distress, in pain, and I've seen it, and I know it, and I know. And I know why they are in. I know what happens. I know what is going to happen. I know how it can. So I have facts. And I tell you, I laid on the table all the facts. So for me to be a counselor, I must be knowledgeable. Good knowledge of that particular subject matter. Okay? Because I've seen where people who claim to be counselors don't have the basic understanding of the process that they are even counseling the patient on. I hope you get what I mean. So you cannot give the right information across if you yourself do not have. So you must have a full understanding of the problem in question for you to be able to counsel somebody. And you are laying everything on the table. This is what happens. This is how you get it. This is what happens when you get it. This is what will happen when, after you get it, subsequently, for your children, for this, for that. And then this is how you can prevent it. These are the treatments. These are the options. These are the things. So the patient or the person that you are counseling makes a choice based on facts, not fallacies, not your own ideas, but what is available, and the patient can verify what you are saying, and he makes a choice. But the important thing is you can guide the person to make a good choice, but you don't impose your choice on the person. Because if you do, and anything goes by, you see, the thing is that it's because you made me to, okay? So you share in that. So I think we need to be very careful when we counsel patients. And of course, the counseling is that it's a genetic thing, is heritable, that you can transfer, you can get it from your parents, and you can also transmit it to your parents. So not only for you, but your children will also have this consequence, okay? So counseling is important. And if people are counseled properly and at the right time, I think it makes a lot of sense. Just as you're saying off camera, it's not when someone is about to get married. It makes a lot of sense. And then let's look at it. Where has it been tried? For example, in Cyprus, I've been to Cyprus because they also have a major challenge with what is called the thalassemias, which is something akin to sickle cell, you know, the hemoglobinopathies. So they've also tried a lot of things about, sometimes in some places they have legislated, this and this should not marry, this and this should not do this. But you see, once you begin to do that, you make people, because I don't know how, somehow, human beings as we are, when we are told not to do something, that's when we enjoy. Like Paul says, that which I know that is not, I don't want to do, is what I do. You know? So when you legislate, you tend to make people to run under and begin to do, and that also fuels the problem you are trying to solve. Okay, I want to bring that to our environment where people are now made to go for genotype testing before they get married. Good intention, because we don't want children to be born with sickle cell. But my problem is that when people come to the church and say, I want to get married, they didn't start yesterday. They didn't just see them on the road as they are coming and then came. So they are even, you know, known themselves, in quotes, grown up to be emotionally attached to one another. So at the point of coming to be joined, we are talking about maybe they want to cancel for, like we do now, 6 months or thereabout. So you are just telling them now they should go and do genotype. I don't think it is the right time. It's a good thing, but I don't think it's the right time.
So when
because
is the right
at the time they are coming, they already made up their mind and all that, and they are emotionally attached. So a good intention becomes something, you know, not too good, because at this time we are going to cause a lot of, you know, emotional. Although it's better to get to, you know, go through this than, you know, go through the
pain.
But then also, but what I'm trying to say is that, you see, if we do it earlier.
Okay, so that's the right time to do earlier.
It's not even, for me, it's not even in universities or youth service camps as we do now. Early as far as primary school. Okay? We always think that children don't know certain things, but they know, and they can be made to know certain things. And the earlier, it's not about talking about marriage, okay? But what is genotype? What are the consequences of people who are incompatible when they have incompatible, you know, situations of genotype? So we begin to teach it as whatever and inculcate it. So already from beginning, they have they know what genotype is. They know how genotype combinations are and what the consequences. So at that level, the curriculum for what you give to that child as primary is not the same thing as what you are going to teach. But I'm saying that even at whatever level, there should be something for these children to know about genotype.
So in our Sunday schools too should be included in Sunday schools and
to teens, and especially at the teen level and youth level. Okay, so you start from the Sunday school. And then I'm not saying that teach them about marriage, and no, that is not what I'm saying. But don't wait to when they are coming and then you say go and bring your. So when you say go and bring your genotype, they go and forge a genotype and come to you. You are not a doctor, so you get them married, and that is also a problem. So I think the counseling should be as early as possible, and it should be stressed, you know, and done away, so that it becomes a part of them as they are growing up. So they already, if we are going to have a relationship, you already have at the back of your mind that whatever relationship I'm going to have, let it not be something that eventually will lead to, you know, because I want to believe that, especially as Christians, if you are starting a relationship, you already have at the back of your mind that this may end up in marriage. Okay, so from the rudiments, it should grow in that light.
Wow,
okay.
You can't believe that we spent all the time for this. Well, it's been an interesting discussion. I think there's so much more to even talk about in this. Maybe we'll invite
you back. Let me just say this, a little bit of this. Okay. Like we said, we're talking about those who want to go in, but talk about those who already have it. What do you do? Okay, because you can counsel to prevent people from getting married so that they don't bring offspring that are sicklers. But those, supposing people are already married, AS and AS, what do you do? And that is where science has come in. Okay, now before now you have what we call the prenatal diagnosis. Okay, prenatal diagnosis in the sense that the woman is pregnant, okay, and at a certain time of the pregnancy, you can test the genotype of the fetus and determine the genotype. So the questions are, what happens when you know the genotype? Of course, there are options. The person goes on to have the baby irrespective of the genotype. The person can abort, okay? So now, do you advocate abortion? Because not even by our own religion, even the constitution does not. So abortion is only permissible when there are certain conditions that can be met. So that a child is AS or SS is not, you know, a reason for abortion. So that is not a solution, and because that can only be done after the woman is pregnant, and becomes ethical problems of abortion and not abortion. So you don't really solve much problem. But today, science has helped to a large extent, which some other countries are doing, where by way of IVF, of course, you know what IVF is, okay? So what does it mean? you get the egg from the woman, the sperm from the man, and you actually, you know, and then develop outside of the womb, and then implant. Now, before its implantation, you can actually determine the genotype. Okay, you can actually determine the genotype. So if you determine the genotype before implantation, you can actually discard, or if it is what you want, you implant. So in this way, to some extent, the issue of abortion really, you know, does not really, although, of course, in everything in medicine, there's ethics and there's morality and all that. So, but this is more acceptable to some people than the other issue of prenatal diagnosis. So this is one way that people have been able to, you know, have children that are not sickle, even when everything appears to be that when they have natural processes, they may have sickle. Okay, so I think it's a very good
very good, please, because we still have a lot of other bone marrow transplants, all of that, but because of our time has been fast spent. All right, thank you very much for coming on the program today. There's so much you learned today. I think we should just go on and talk more and more and more. Thank you very much, sir.
Thank you. Because I've tried to talk very slowly, and I mean explain this thing because I wanted people to really understand the basics, because I'm not going to talk too much about the medical terms. Yeah, that is not the issue here, because I want what can the person at home really get from this issue, because I don't think too many people are ignorant about what sickle cell, although they may have misconception, but we know. But are we doing what is right, and do we have the basic knowledge of what sickle cell is all about? Okay.
All right. For the past, I think, 15 minutes to 1 hour, I've been speaking to Dr. Tamunomieibi. Tamunomieibi Wakama. He's the consultant hematologist at the National Hospital, Abuja. Thank you very much for coming on the program.
It's a pleasure.
And we hope to call you back some other times.
Any day.
All right. Thank you very much. So
thank you.
I want to believe that you have learned so much today on sickle cell disorder. And if you're living with that, listen to what we have talked about, and that can help you on how to manage, and even for those that don't have it, but how to prevent this from happening. I'm Angela Mweze. I'll come to you next week with another episode on this program. God bless you. Bye-bye.